Hello, everyone, and welcome to today's webinar. This is the second webinar of our webinar series of the virtual assessment in Lewy Body Dementia, the pandemic and beyond. Today's webinar is understanding the current research on the virtual assessment in this population. This webinar is brought to you by the Lewy Body Dementia Association Research Centers of Excellence. For more information on that, please go to the LBDA.org website. I'm Dr. Catherine Amadeo, and I'm a neurologist and movement disorder specialist at Westchester Medical Center. Next slide. Before we begin today, I just have some housekeeping notes. So today, this is a live activity. It is being recorded. It will be available within 2 weeks on our LBDA YouTube page called LBDA TV. Like I said, within 2 weeks of this presentation. All of our attendees today are muted, but we want to hear from you. So please, during the presentation today, please write in questions into our Q&A function. I'll be monitoring that, and we'll have a nice monitored Q&A session at the end of our presentation. So please feel free to ask questions throughout. If we don't get to your question today, we will follow this up with emails. So please, there'll be emails after this for evaluations of work, so keep an eye on that. But we'll also be answering some questions that we don't get to in that way. Next slide. So as I said, today's event is brought to you by our LBDA's Research Centers of Excellence program. It was organized by our Clinical Care Professional Education Working Group, for which I serve as co-chair with Dr. Jennifer Goldman. And again, we're very excited to bring this series to you. Next slide. This was supported, these series were supported by an educational grant from Acadia Pharmaceuticals, for which, we're grateful. We were able to get accreditation for these series today, and this is worth 1 CME credit. So you'll be again getting a slot, an email after today's presentation with evaluations. Importantly, if you're here today in a group, if there's several of you listening in, please email Miriam Giles at mgiles@lbda.org following this with your name, so individual names and emails, so that you could be sent an evaluation. Next slide. Yep, as I said, this is worth 1 credit. Okay, and that's next slide, yeah. So these are our disclosures today. We are so excited to be joined by our expert presenters today, Drs. Dag Arslan and Andrew Owens, and you'll be hearing from them in just a minute. Next slide. And so our agenda today, again, following the presentation by our expert speakers today, we'll follow with a panel discussion with questions and answers. So like I said, please feel free to be asking questions throughout. I'll be moderating that session later today. These are our objectives. What we want our attendees to come away with is an understanding of an update on research in this field of the virtual assessment LBD, and discuss the application of these findings to our clinical practice. Today, we will not be talking about diagnosis or treatment of LBD. That's beyond the scope of this particular talk. And without further ado, I'm going to introduce our expert speakers. And so we're starting with Dr. Dag Arslan, who's a world-renowned LBDA expert, and we're so excited. Thank you.
Thank you, Catherine. Hello, everyone. Good morning to those of you in the US. It's afternoon here in Norway, where I am sitting. So it's a pleasure to talk to you about DLB and virtual assessment together with Andrew Owens. So we are both affiliated with King's College London, and there are 2 reasons for why we are here today. My background, as Catherine said, I've been researching DLB and also Parkinson's disease dementia and related conditions for many, many years. And in addition, recently, together with Andrew and others, we have been more and more interested in remote assessment. So we are leading a large European multi-center project to understand which of the available remote virtual devices to measure a variety of cognitive and non-cognitive functions in people with Alzheimer's disease at early stage can be used in the clinical world. And that combination of being interested in virtual assessment and DLB is the background for this presentation. And both Andrew and myself are very keen to take our experiences and learning from the virtual technology results from the Alzheimer's field into DLB. We both think there's a lot of mileage and lots of opportunity to use these technologies in DLB. And obviously, the current situation with the pandemic, this has been become an even more relevant topic. But we've been in this space for several years before we knew about anything about coronavirus. So maybe the first slide, please, Angela. So that was the end of it.
My apologies. We must.
No worries.
The current slide up. 1 second, please.
That's fine.
That's not at all embarrassing.
No, fine. Allows me to keep on talking then. So we've had the first webinar about diagnosing DLB, and Catherine said we will not talk about diagnosis, but in some aspects we will, because we think that these remote technologies can actually help also in diagnosis in addition to monitoring the progression of the disease. So as you have heard, dementia with Lewy bodies is a second most common form of dementia. Approximately 10 to 15% of people with dementia have DLB. But we also know that it is a neglected area and that many people are underdiagnosed and under-treated, and it's also an under-researched subject. So we are really keen to promote interest in DLB, and I think this webinar is a fantastic opportunity to spread important information. So as you also probably are aware of and have heard about, there are some key features of DLB. So in addition to the cognitive impairment, which is required for the diagnosis of dementia, the key features are fluctuating cognition, recurrent visual hallucination, REM sleep behavior disorder, and Parkinsonism. And to the right, you can also see that there is a variety of underlying pathologies, Lewy body, but also Alzheimer's type pathology. So getting the right diagnosis is not always easy. And this slide also shows the term prodromal DLB, and there is an increasing focus now on the earliest stages of the disease before dementia is developed. And that means even greater challenges from a diagnostic point of view. So today, we diagnose these symptoms or changes by using physical assessment, doctor's appointment, and a number of clinical rating scales. Cognitive testing using the MMSE or the MoCA, fluctuating cognition. There are specific scales for that. That's, by the way, it's a particularly challenging symptom to identify and rate, an important one because it's a really key diagnostic item. But that's also a symptom which is probably particularly relevant for remote assessment. And the same with hallucinations. It's a questionnaire, and REM sleep behavior disorder, also a questionnaire for a partner, also something that can be nicely assessed technologically. And then we have Parkinsonism, the motor features with tremors and slow movements and stiffness, as you will know. Also a symptom or syndrome which lends itself to virtual remote assessments. Next slide, please. So, as you also are aware of, DLB has poor prognosis, and since diagnosis is complicated and people are underdiagnosed, we know that the outcome of many patients the DLB is poor, and early accurate diagnosis is therefore important in order to initiate management strategies that can help and support the patient, the carers, and the families. So in addition to the clinical diagnosis, the clinical assessments, there are a number of biomarkers. We won't touch upon that now, but as you know, DAT scan and MRBG and other imaging, and maybe even blood or cerebrospinal fluid can be used to reliably diagnose DLB. But clinical assessment is the key factor, and the biomarkers are usually often expensive, and some of them are invasive and not always used. So what can we do in terms of virtual or remote technology? So in general, there are some features with these technologies that are particularly interesting for us. So with these technologies, which can be applied to smartphones or wearables or iPads or even computers, desktops, laptops, etc., they can remotely and actively or passively assess a variety of very relevant, let's say, behaviors or changes, activities. That can be mood, it can be cognition, gait, function in everyday, and also sleep and other relevant symptoms that can be assessed using remote technologies. So remote technologies then offer the opportunity to frequent and even potentially continuously monitoring features which are relevant for the patients and relevant for diagnosis, and which can be difficult to capture in the clinic, and also can be captured much more frequently. And as I mentioned, fluctuating cognition, fluctuating attention is one particular aspect which can be difficult to capture remotely, and which can be captured using remote and digital technologies. So the remote technology can also aid in terms of providing context. For example, is there activity? You can use an activity measurement, but then you also would want to know, is the person sleeping or is the person awake? So low activity is normal, and what we want to see when we are sleeping, and vice versa, when awake, we want to see normal activity levels. So that's where these devices can help us. Next slide, please, Angela. So again, to sum up, these technologies can remotely and passively, without the person doing anything, help assess changes in behaviors and mental states. Can use these monitoring very frequent and even continuously. And that way we can, as this slide shows, we can fill the gap between different clinical appointments, and we can also even reduce the need for clinical appointments. We can reduce the frequency because these relevant areas are measured remotely in the patient's home, normal daily life, rather than having to go to the clinic, sit down with the doctor and talk and try to remember what has happened during the last 2, 3, or 6 months. So that's why remote technologies can offer an incredible help. And I think now the next slide will be my last before I leave the stage to Andrew. So we think that these remote technologies can really improve our ability to diagnose and monitor a number of disease states, including DLB, due to the fluctuating and the wide variety of symptoms. And this can then help us really to improve diagnosis and even prevent a worsening of the condition. And Andrews has led several recent papers which can be accessed by you and probably can be made available from the LBDA on how to use these remote devices, also how they can be used in clinic, not only in sophisticated research project, but in clinical practice. And that's what we are aiming to identify. How can this help us in the daily work with patients. And Andrew, please, can you take over?
Thank you, Dag. Can we have the next slide, please? Okay, so as Dag mentioned, we're not looking to replace current clinical practices with remote measurement technologies, or RMTs as we call them, but what we are looking to do is enhance current clinical practices by, for example, using RMTs to collect clinically relevant data in between clinic visits as the patients go about their normal everyday lives. And so now we're just going to give an example of one of these initiatives. That's our remote brain health clinic. Can I have the next slide, please? So COVID-19 has heightened the need for remote cognitive assessment because older people are at high risk from COVID-19 because of things like existing physical and mental health conditions, as well as having smaller social networks. So older adults are particularly recommended to minimize risk of infection by using social distancing measures. But the importance of a timely diagnosis of dementia is unchanged. In fact, it's got arguably more important because of the association between COVID-19 and dementia. Can we have the next slide, please? So we know that the social distancing measures put in place in response to COVID-19 were vital, but they did have the unintended consequences of reducing physical activity and social interaction, whilst at the same time increasing loneliness and depression. And these are all factors that are associated with more rapid cognitive and functional decline. There's also the dilemma faced by any patient with concerns about their cognitive status during the pandemic, and that is they will want to speak to a clinician about their concerns, but they will also want to minimize their risk of exposing themselves to COVID-19. Can we have the next slide, please? And we think that remote assessments can potentially resolve this dilemma, as well as providing an opportunity to look again at how we carry out current methods, and can these be adapted for current and remote assessments. But of course, there's a number of challenges and hurdles that have to be negotiated, such as variations in internet access and computer skills. Of course, digital medicine is a new field, so there's a limited evidence base. That's why it's important that we share any experiences in publications as we go along. And folded into any approach like this is the regulatory and data protection issues inherent in this approach. Next slide, please. So this schematic really gives an overview of our first remote brain health clinic model that we initially put in place in response to COVID-19. The basis of the model was a video interview where the clinician just used a simple teleconferencing platform to become acquainted with the patient and carer, establish a rapport, and take an unstructured history. And then there was a three-tiered approach, each tier slightly more involved and advanced than the previous tier. So level one was simply using a teleconferencing platform to carry out the scales and the questionnaires, and using the share screen option for any visual tests. Level two was slightly more advanced, where we use specific and validated digitized versions of these tests and questionnaires. And we found generally that levels 1 and 2 together were sufficient to make a diagnosis of dementia. We found for the more nuanced deficits in cognition and function seen in mild cognitive impairment and subjective cognitive decline, so the pre-dementia stages, that more involved in advanced technologies were required, which led into our second model, which we're about to roll out. So if we can have the next slide, we'll take a look at the second model. And you'll see now that the first visit takes place in clinic, on site in the hospital. And we list there in the left panel the assessments that take place. And then 12 months after that appointment, you'll see in the right-hand panel that there's a clinical assessment and a report of the remote assessments that took place in between the two in-clinic visits. The patient carries out an acceptability questionnaire to give their feedback on how they found those remote assessments. And then they then have the option of re-entering the remote assessment option in between their next clinic appointment. And now in the middle panel, you'll see that we've kept some of the assessments from the first model, such as the telephone interview for cognitive status. We found this worked very well and all you need is a telephone for it. So it's very cheap, very easy to deploy. But we've also added some slight advancements as well, such as saliva biomarker analysis. This is where we're working with Cytox to see if we can roll out their saliva biomarker analysis. So that's sent to the patient's home, and they then post it back to the labs for analysis, and we receive that report. We're also working with Vimea, a tech company, to look at neurolinguistic profiling, as well as, of course, functional assessment, such as looking at activities of daily living. Could we have the next slide, please? So as I say, this second model, which we're about to roll out, and we're delighted to say our NHS Trust has said can continue even after the COVID-19 pandemic has passed, is looking to draw on our experiences from the other RMT studies that we are working on and the other collaborations we have ongoing with relevant tech companies. An example of that would be remote EEG. So EEG is very useful for clinical and research purposes in DLB, particularly for defining distinct neurophysiological signatures. But the studies that have used this approach are typically lab-based and for short periods of time. So we're thinking that with the remote brain health clinic set up, if we can deploy remote EEG, we will have much longer time periods to capture relevant EEG data. So in collaboration with MIT, we're about to roll out a feasibility study using their attentive view remote EEG and electrooculogram in MCI patients in our remote brain health clinics. And we're doing this with a view to see if we can aid early differentiation of DLB from AD, as Dag mentioned at the top of the talk. They're very early, very difficult to differentiate in the early stages. And we're also looking to see if we can capture even higher resolution EEG signatures of DLB related symptomatology, such as the fluctuations in cognition and alertness, and also visual hallucinations. So this, of course, is clinically important as well, but also as clinical research importance potentially. Next slide, please. So Dag mentioned the relevance of REM sleep behavior disorder. Idiopathic REM sleep behavior disorder is a strong early indication of subsequent phenoconversion to Parkinson's disease or DLB. And it occurs, as mentioned, in about 76% of DLB cases. And there are remote polysomnography devices out there. For example, the Dream headband, which has devices and features embedded in it, including a deep learning automatic sleep staging algorithm and physiological signal acquisition. So we're working with the Dream company to roll out the Dream headband in our remote brain health clinics in early to moderate dementia to see if we can capture remote sleep profiles. Next slide, please. And this is really just an idealized version to show you what is potentially possible using remote measurement technologies in relation to DLB. So we just mentioned that we can look at neurophysiological signatures using remote EEG or remote polysomnography relevant to things like RBD and visual hallucinations and fluctuations in cognition and alertness. But we also have the option of looking at motor symptoms, of course, very relevant due to the Parkinsonism, by looking at gait and posture. This is something we're also doing in other studies in dementia cohorts. And then you have the option of looking at the autonomic dysfunction that we know happens in dementia with Lewy bodies. So for this, you can look at cardiovascular domains like blood pressure and cardiac function, thermoregulation such as anhydrosis and hyperhidrosis, and even gastrointestinal function using remote electrogastrograms. Next slide, please. So to summarize, remote measurement technologies can enhance current clinical practice that relies on face-to-face subjective self-reporting. It negates patients and carers commuting to clinics as often. It can potentially help diagnosis and symptom management. It can collect clinically relevant data in between clinic appointments and offer valuable insights into disease progression and treatment responses over time. It can range from standardized low-cost telephone interviews, which as I said, we're using in both models of our remote brain health clinics, to consumer-grade wearables and bespoke apps or sensors. And all this is with a view to aiding the evolution of current diagnose and treat care models to a predict and preempt approach. And I think that's the last slide. Thank you very much.
Thank you so much, Dr. Owens. That was excellent. Thank you, Dr. Arslan. Excellent. So I just wanted to remind our attendees today that please feel free to ask questions through the Q&A option today. And it looks like we have got one. And then I also have a few questions I'll ask in case. Okay, so we have our first question for either Dag or Andrew. What are the costs of remote measurements?
Well, that really depends on what you're interested in. So whatever domain it is, there tends to be the more sophisticated the option, the higher the cost can be. But we found that if you build a good relationship with the tech vendor, then you can get negotiations early on at the feasibility study stage where maybe some of those costs are either waived or reduced. Then you get a grounding or an evidence-based to then apply for grant funding, which then allows for a more substantial collaboration.
Mm-hmm. Yeah. Do you have anything to add to that, Dag?
Well, it's also related to the second question about whether it's reimbursement, and obviously these are early days, as Andrew mentioned. So it's still, I mean, none of these are kind of included in guidelines yet. But that's I think that's only a question of time that that we can see. I think we will see a gradual increase in the use of these devices, and also increase in the sophistication of the various devices that can be used. So one of Andrew's last slides where this person was kind of filled with devices all over the body. I mean, that's probably not to happen in the next couple of years. Mm-hmm. Maybe that's good, but that some simple devices can be used. And one example from practical life is the kinetographic that is used in Parkinson's, the PKG, I think. I think that's already fairly established, and that can also be used in DLP. Whereas all these others are more novel. But then the telephone interview for cognition is extremely simple, of course. So that's validated and available, and I would be surprised if not reimbursed. I don't know the rules and regulation for that in the US, but I think it's an evolving process, and it's early days, but there's a huge interest in this topic. So I'm also fairly sure that in a couple of years we will know much more than we know now.
Yeah, I think you're absolutely right. And just to comment on that, when I think about how, we were really just even clinically seeing patients remotely with grants. And now, because of the pandemic, we're doing it, insurance is supporting us. So I think that's why your work is so important, because there is going to be a time for it. And so we're getting a lot more questions now, which is great. One question is can you speak a little bit, and again, either Andrew or Dag, about the diagnostic accuracy when, between at-home tests versus in clinic or in person? I know, we have a lot more to learn about that, but can you speak a little bit about that?
Maybe, Andrew, you start, and then I can extend if needed.
Yes, so how did the remote assessment data compare to the data collected in clinic?
Yes, I know we have some work on that in Parkinson's, but if you want to speak a little bit about that, Andrew.
Yeah, well, as we mentioned, we're definitely never looking to replace that in clinic assessment in terms of the importance of the clinician having that face time with the patient. We're really looking to supplement that one-off visit that happens once or twice a year with relevant data that comes from the remote assessments. We don't think it would be possible to necessarily make a diagnosis from, as Dag mentioned, the difference between active and passive assessment. So the passive assessment is something like when a Fitbit collects your steps, you're not actually telling the device anything. I don't think you could ever make a diagnosis from that kind of passive passive data collection.
Yes, I agree. And you know, the diagnostic process includes a lot of, let's say, activities, and some of them, and many of them actually can be done remotely, but not everything. So I think we need to be always be careful about that. So blood tests, for example, or a physical exam, checking the lungs, and so there are some kind of, let's say, the physical examination elements that need to be done, but that can also be done by the GP, and then if you have a good GP relationship, things are done. I think some of the more specialized diagnostic elements can be done, or many of them can be done remotely. Obviously not imaging or let's say biomarker collection, but a lot can be done. So I think it's not about whether everything can be done, but how much can we do remotely to save cost and stress, but also which elements can remotely be done which are more accurate. And I think it's also important to stress that it's not only because this is practical and simple and safe and cheap potentially, but it can also improve the accuracy and this continuous monitoring of particularly the fluctuating symptoms like the cognition. I think that's such a brilliant example of where remote devices can be used. We don't know exactly how that works yet, but that's clearly something to tease out.
In your, your research at this time, somebody brought up a question, are in-person evaluations necessary? How do you incorporate in-person evaluations into your remote work? Do you have the participants also come in for in-office evaluations?
Andrew, I think you can.
Yeah, Andrew, if you want to answer.
Yeah, so we're still at the stages really where for the deploying the equipment or putting the apps on the patient's phone, we want to have that face-to-face visit. So during COVID, sometimes even for research purposes, that would then involve going to the patient's home. But even then that gives you useful real-world data to see how is the patient living, how are they adequately supported at home, and if they have a caregiver that's a family member, how are they, and because that's something else to consider, is that it's very important to get input from patients and carers throughout this process. We have quite a few patient advisory boards, and it's very interesting because as I said, that this is still an evolving field, a new field, that there's a real lack of sort of literature on it, but particularly from the patients and caregivers side of things. So it's often quite surprising what you hear from them. They want to be engaged with remote measurement technologies because it feels like they're doing something proactive in between those clinic visits. It feels like they're in some way contributing to their own health and well-being, even if that's just to feed back information to the clinician.
And that speaks to attendees have asked questions about, can the care partner be involved? And it sounds like indeed yes. And Andrew, can you speak a little bit about more how the care partner is involved?
Yes, so often it's important because there will be technical issues. There's no point denying that. That's a participant or patient manual that's written in simple terms, and that's why that face-to-face visit at the beginning is very important, whether it's in clinic or whether it's in a hospital, because you need that face-to-face time to say, just go through the manuals with them, give them some very digestible, easy to understand information about this is the device, this is how long the battery lasts, this, and then practically show them how to put it, or practically show them how to use it on their smartphone, or on the software platform if it's on a computer, and then highlight this is the number that you call if you have any difficulties. But likewise, the good thing is as it's evolving, that we have our own dashboards at our end, at the back end. So as soon as we see a data stream drop out, then we can say, okay, it looks like that there's an issue with this device. Maybe we should give them a call.
Mm-hmm. Thank you.
Yeah, can I add to that? I fully agree, Andrew. Well taken. But it also depends a little bit on the, let's say, the level of impairment. And let's say early stage patient, I think they can handle a lot of this stuff themselves. But then with let's say more evolving cognitive impairment and to the level of dementia, obviously the need for kind of help and support in setting it up and monitoring the devices are needed. So that it's kind of a trade-off as it often is in other aspects as well.
Thank you both. Actually, Dag, I'm going to direct this next question to you, which kind of goes off of that understanding, you know, our patients with LBD and you know, the inherent features such as fluctuations in cognition and level of alertness. I can certainly see challenges with research in this population. But then, as you said, I could also see the benefits of remote assessment when I think about those things, particularly the motor features. Can you speak a little bit about your, you know, thoughts on or your experience with doing research remotely in this population, the challenges and benefits?
Yeah. Well, I wish I could, because I wish we had set up studies in this population. We haven't, but we are very keen to do so. Currently, what our research experience is related to let's say the Alzheimer's space and particularly milder degrees of dementia or MCI. So in that perspective, it works well, but it is a very different challenge. Let's say easier, but also more complex. But easier because it's cognition focused. So and there's functional decline, but the function is cognition related. So that makes it somehow easier because that's the focus. In DLB, LBD, as you all know, there are a variety of spectrum of different clinical symptoms that needs to be measured. So that poses a challenge, but it also poses an opportunity because it really offers an opportunity to simultaneously monitor a number of symptoms, which is let's say in a clinical interview very, very challenging and difficult. We go through, okay, let's start with movement and how's that going? Thank you. No, let's move to sleep. And then it's kind of, in the end, everyone is exhausted and the kind of information might be less reliable. If by using these monitoring devices, I'm very confident that we can get much more valid, relevant data. So I think this is really something where we should work together and set up a research program on this. And I hope Angela is listening. I'm sure she is. That's something we should promote. We should kind of see how we work together with the different expertises in this area.
Yes, and we have a comment in the Q&A that one of the attendees, Joy, is a member of the PD Avengers in the research department, would be very interested in this work. So thank you for that comment, Joy. So I think we should certainly be thinking about the collaborative efforts, and that's what's so great about this.
Sorry, just to add to that, because I think it's extremely important to do the research. That's what this project that Andrew mentioned, the radar, it's about validating the various and selecting and making a kind of critical, informed decision which of these myriad of devices that are out there and can be very confusing and very tempting are actually good, giving us the data that are accurate, that are feasible, following data protection, regulatory issues, etc., etc. So we need to do this research. We can't just go to the internet and buy something and put it on the bodies. That's very, very important.
And that's what speaks to a lot of earlier comments about insurance reimbursement. We need this research. Yes, exactly. One of our attendees is asking questions about security with remote assessments, which I know comes up a lot even when we're talking to our patients. I don't know if you want to speak a little bit about how we protect security with the remote assessment and you know, patient data. Andrew, I don't know if you want to.
Dag, shall I answer that?
Yes,
so
yes,
that's actually an important question. to start with any tech company that you're looking to collaborate with. That's one of the first things you need to ask them is, okay, this is obviously clinical and personal information. What do you do with that data? How protected is it? And also for the ethics process, that's a very important thing that you need to appease the ethics committees with, is how is the data collected? How is it anonymized? How is it stored? And how is it accessed? Where is it stored? And you do need to have a clear plan for that. And that's often where it becomes very beneficial to work with specialists in the technology area, because you can't expect a clinician to find their way around that and understand that that's really something specific that needs to be provided by the tech experts, so that they can ensure that this data is stored as safely as it can possibly be stored, but also then it is delivered to us in a way where we can analyze it or assess it in the best way that we can.
Yes, I fully agree, Andrew. And can I just add to that? So we are now speaking from a researcher's perspective. So when we say ethics, that's we are submitting these projects to ethics committees. I have their comments and back and forth. So this is in a research setting, which obviously there are high demands, particularly high demands in research that safety is covered. But then next challenge is then how can we then translate this into clinical practice? And that is an issue that has not been settled. But that's where we are working. We are working with the informatics groups within our NHS, within the hospital system. So obviously we have electronic record system, and so how can we have data from these devices feeding into the health record system in a way that is easy accessible for the clinician, at the same time safe? I think that's definitely not trivial, and I'm glad it's not my task to find a solution. But I mean, it is a technical question, so there is a solution. But it just has to be made. And one of the questions is, can we prevent hacking? And obviously, hackers can get into everywhere, Pentagon or wherever. I mean, that's never 100% safe, but at least a decent level of security.
Right. I can imagine it being something built into, a sentence on that, into the informed consent, as with other studies, where we we're going to do our best, but there's only so much, right? I have a question. So, and Andrew talked a little bit about this too, that we know with the synucleinopathies that autonomic dysfunction is a key feature and often presents as orthostatic hypotension. Now, when we think about fluctuations, it's something that I think I and others can help but kind of think about. Is orthostasis part of that? Is there, can you speak a little bit about how the blood pressure monitoring can occur? Is it something that can be 24 hours? Is it something that is just, can you just speak a little bit about those devices? So I think those will be really important.
Yeah, so we've been able to measure blood pressure using ambulatory monitors for quite some time now, maybe 20 years, but that's intermittent blood pressure monitoring. So what often happens is you give the participant a protocol with a view of what form of dysautonomia you're interested in. So if you're thinking of DLB, you're thinking of autonomic failure, orthostatic hypertension. So you're looking for something like postprandial hypertension, get them to stand up after they've eaten a meal, and then ask them to activate the blood pressure cuff. So even that is, it's surprising that once you get the patient out of the clinic, it's a very basic approach. It's been around for a while, but once you get away from the clinic, away from the white coat syndrome, you do collect some very relevant data from that very crude approach. Mm-hmm. So the good thing about the advances in RMTs, which are always ongoing, is that now we're looking at wristwatches that capture continuous blood pressure. So you would maybe say it's slightly less accurate because it's not the brachial pressure, but also you you offset that really, which is a big part of selecting these devices, is you play one win off against the loss. So what you're gaining here, say in battery life, you may be losing in accuracy or something like that. You know, that's how you make the decisions. So it's really expanding that window of opportunity. And I'm sure with DLB, you're going to capture more unique dysautonomic signatures. And I said in the talk as well, you can even look at the anhydrosis and the hyperhidrosis as well using the digital camera and the app that goes with it. And like you're saying, with something like fluctuating cognition, if the patient's seated and a fluctuation in cognition and alertness is detected, then that's not likely to be due to cerebral hypoperfusion because they're seated. Whereas if something happens when they're upright during orthostasis, then not only is that probably due to autonomic failure, but they might faint, they might go over. So that's where we look down a line and say, well, actually, then maybe there's some sort of thresholding that can go on where we're looking at a drop in blood pressure. Someone needs to quickly go to this person.
Yeah. You bring up a really good point that, these remote assessments will allow for, in a way, almost, more readily available data that, we're often not getting in the clinic setting, that real time data. So that's really, really great. We have a question about are any coordinated research studies in the planning stages that will utilize these technologies discussed today? I think.
Well, as I mentioned, we have this Alzheimer type research that we are doing, and I know there's a lot also ongoing in the Parkinson's disease, but unfortunately, at least to my knowledge, you guys can correct me, but I'm not aware of anything going on in DLB. So that's really an area of where we should focus. Well, in general, we need more DLB research, but this is, as we have discussed now, this is, I think, particularly well suited for DLB type project, and there's a lot to learn. And one element we haven't discussed too much yet is the nighttime changes, the sleep changes. I think that's also a fantastic, very easily accessible, let's say, behavior that can be measured quite reliably. Andrew mentioned the dream ahead, but more of sophisticated sleep stages. But even just sleeping or not sleeping is something, and what's happening, but in terms of nighttime behaviors and that kind of quite crude measurements that can be done and give a lot of information, which will rarely be captured by a clinical interview because might not have been, nobody might have noticed it and or made a record of it. So that's an opportunity also.
Yeah, I think collaboration with our sleep colleagues would be really, really vital, especially when we think about, REM behavior being just such a key biomarker in this population when we're looking for earlier diagnosis. I mean, like you said, the opportunities are here. We got to do it. Okay. So, let's see. I think those were the big questions. And if anybody else has any more questions, like I said, please feel free to email. But I think if there's nothing else, then that was an excellent presentation today, and we're really, like you said, it really got us all motivated and thinking, and to hear about all the valuable technologies we have, and now just thinking about how we can make that happen. So I'll turn it over to Angela, who's just going to do some a little bit of housekeeping at the end to talk about our future opportunities. Thank you both, Andrew and Dag, so much.
Thank you.
Yeah, and please let me reiterate, Dr. Amadeus, thanks on behalf of LBDA, our research centers of excellence. To our audience, we really thank you for joining us today. Please do visit lbda.org to find a whole host of resources for healthcare professionals, families, the general public about the disease. Want to remind everybody also that we have, advanced here for you. Participants who complete an evaluation of today's session can obtain free CME or a certificate of participation. The instructions will be provided to you in an email that will be sent out to you shortly. Today's session was recorded and will be posted on our YouTube page, LBDA TV, in a few days. You'll be notified when that's available for viewing, and please do share it with your colleagues. LBDA is hosting one more webinar in this series with the aim of expanding the knowledge and understanding of Lewy body dementia. So visit our website calendar for more information on that as well. As you can see, the next date will be May 17th. And also available through our website is a CME through Medscape. So we hope that you'll share those with your colleagues and trainees as well. Again, thank you for joining us today. We're delighted to have you. And on behalf of LBDA, I hope you have a very nice day. Thank you very much.